All right, looks like we're live. Hopefully you guys can hear me okay. There's a little bit of noise in the background, so let me know if there's any issues with that. And if you're typing, if you're watching the replay, please type replay in the comments. I'd love to hear from you and any thoughts on what we're discussing today. So today we're going to be talking about sleep workup essentials for outpatient practice. And the reason I wanted to share about this is because what I see happen a lot is that physicians and therapists will jump to interventions for sleep before fully understanding what is going on with the patient's sleep. And I see this all the time. Like in Facebook groups and things, people say like, oh, my patient has insomnia. What medications do you recommend? Or what supplements do you recommend? And those are helpful questions to ask and helpful things to know. But we need to take a step back to really understand what is happening with the patient's sleep. So we're going to look at how you can start that assessment. If you don't know me, I'm Nishi Bhopal. I'm a board-certified physician. I'm specialized in sleep, integrative psychiatry. So I look at things through an integrative holistic lens and, of course, using evidence-based assessments and treatments for sleep disorders and psychiatric disorders. And I have a YouTube channel and an online course teaching physicians and therapists about clinical sleep medicine. So let's jump in and talk about some ways to start assessing your patients. And if you're watching the replay, go ahead and put in the comments. Just let me know where you're watching from, what your specialty is, and if you have any specific questions about assessment of patients with sleep issues or what your biggest challenges are treating sleep issues or assessing sleep issues in your practice. I would love to know the kinds of things that you're struggling with. So we're going to talk about differential diagnosis of insomnia, which is really where you want to start. And then I'm going to share a framework that you can use to assess sleep issues with your patients. So we need to remember that insomnia isn't always insomnia, right? So patients will come to us and they'll tell us that they have insomnia or they're struggling with sleep, and they use this term insomnia, and it may not actually be what's going on. So that's the first thing that I have in my mind when a patient comes to me complaining of insomnia or complaining with issues with sleep is, okay, let's take a step back and see, is this really insomnia or is it something else? So the definition of insomnia is difficulty falling asleep or staying asleep at least 3 nights a week for 3 months. So that's the definition of insomnia. But there are some common differential diagnoses that I have in my mind when a patient comes to me with a complaint of difficulty falling asleep, staying asleep, or waking up too early. So there's 4 main diagnoses that I have in mind. These are obstructive sleep apnea, circadian rhythm disorders, restless leg syndrome, and then hypersomnia or narcolepsy. That one's a little bit less common, but interestingly, it can show up as insomnia because when people have narcolepsy or sometimes other types of hypersomnias, they get sleep-wake intrusions, so there's no clear distinction between their sleep state and their awake state. So it can show up like insomnia, difficulty staying asleep and feeling unrefreshed and things like this. So those are the 4 main differentials that I have in mind. So obstructive sleep apnea, circadian rhythm disorders, restless leg syndrome, and then hypersomnias, including narcolepsy. And then, of course, insomnia. So a patient can have insomnia, but we want to make sure it's not something else. So I'll share a couple of examples. So there was a patient that I saw in the sleep clinic when I was working in sleep clinic a number of years ago. And he was just a young guy, like he was in university, must have been about 19 or 20 years old. And I was covering for the other doctor that day, the other sleep doctor. And this young kid was on Ambien, and he had been on Ambien or Zolpidem for years, since he was in high school. So I think, at the age of maybe 15 or 16, and he had been prescribed Ambien. He was taking it every night for a diagnosis of sleep onset insomnia. So whenever I see a young person like this who has been diagnosed with insomnia and put on a hypnotic like Ambien or some other kind of sleep aid, my spidey sense goes up, right? So I'm thinking, wait a minute, does this kid actually have insomnia that warrants use of these medications that may not be ideal for long-term, that were never designed for long-term use? So we went back, took a full history, And it turned out that he didn't have insomnia. He actually had delayed sleep phase syndrome, which is a circadian rhythm misalignment. They're called circadian rhythm disorders, but I think of them more as misalignments because I kind of think of circadian rhythm misalignments as kind of a natural variant. We all have different body clock variants, and I feel like disorder can be a little bit pathologizing, but it can be very challenging for people when their body clock or their circadian rhythm is not aligned with their daily obligations like school or work or other things. So this kid had a delayed body clock. It was not aligned with his school schedule. He was diagnosed with insomnia by his sleep doctor. And this is important because many sleep doctors didn't have to do a fellowship. So there's lots of sleep doctors who were grandfathered in before it was required to do a fellowship in sleep medicine. So there's lots of sleep docs out there who focus primarily on sleep disordered breathing or sleep apnea, who didn't get much training in other types of sleep disorders. And that was the case with this patient. So, he was slapped with this label of insomnia and given Ambien, which is, I think, kind of heartbreaking, right? Like for a young person to be now reliant on a sleep medication like Ambien. So anyway, so we did the assessment. Turned out he had a circadian rhythm issue. And so we had a discussion about that and what that means and how we can approach that. And we used light and melatonin and slowly started tapering him off the Ambien. And this was so empowering for him. He was so excited that he didn't have to rely on this medication any longer and that there were other things that he could do. So that's one example of why it's so important to remember that insomnia isn't always insomnia. We don't want to take that diagnosis at face value. Okay, I'll share another story, which is a 48-year-old woman that I saw in my psychiatric practice who had been referred to me for sleep issues. And she had been diagnosed with anxiety and insomnia, and she'd been prescribed trazodone and some other psychiatric medications to help with her anxiety. And she'd been struggling with sleep for years, and her primary complaint was middle insomnia. And I forgot to mention for the first patient, the young kid, his primary complaint was sleep onset issues, which is consistent with that delayed sleep phase. So for this woman, her chief complaint was middle insomnia. So she was waking up through the night, having trouble getting back to sleep, waking up unrefreshed, feeling really tired during the day, having anxiety about going to bed. So she was diagnosed with insomnia. So again, we take a step back, think about our differential diagnosis, and then do an assessment to see, okay, wait, is this really insomnia? Does she need to be on these medications? Does she need CBTI? What do we need to do with this patient? So it turned out that she had one of those other differential diagnoses that I mentioned, which was obstructive sleep apnea. And this one is also really important to remember in women because women are underdiagnosed when they have sleep apnea. So oftentimes in women, sleep apnea can show up in a much more subtle way than it does in the classic sense. We think about the overweight male with the 17-inch neck with loud snoring and gasping arousals. That's kind of the classic picture of sleep apnea. But in women, it can show up like chronic fatigue, like depression, low mood, aches and pains, almost fibromyalgia-like symptoms. So it's often missed. And so women are often not sent for sleep studies when they actually have some of these more subtle signs of sleep apnea. So I suspected it in her. I sent her for a sleep study, and she was diagnosed with sleep apnea and started on CPAP, which had a great impact on her sleep quality. The other thing that I like to do, which we'll talk about in more detail in a minute, is to ask them about their bedroom, right? Ask the patients about their sleeping environment. And for this patient, it turned out that not only did she have sleep apnea, she was sleeping in this tiny little unventilated closet, essentially, in her studio apartment. I'm based here in the San Francisco Bay Area, and so there's some very small spaces that people live in. And so she was living in this little studio, and she had this little tiny closet that she turned into a bedroom, and it was unventilated, it was dusty, it was dingy, it was just not an inviting place for her to sleep. So not only was she having trouble breathing from her obstructive sleep apnea, she was also struggling with breathing in this unventilated room, and she had anxiety about going to bed in that room. It just wasn't inviting, right? So I had her move her bed out of the closet into a more ventilated area in her apartment, and she got her sleep apnea treated, and she was able to taper off her sleep aids, and it turned out she didn't actually have a diagnosis of insomnia. So that's point number one. Insomnia isn't always insomnia. And if you're listening or if you're watching the replay, I would love to hear from you. How many sleep disorders do you think there are? Because I've mentioned 4 differential diagnoses, which were obstructive sleep apnea, circadian rhythm disorders, restless leg syndrome, and hypersomnia and narcolepsy. But there's a lot more sleep disorders than that. So I'd be curious to hear, just put in the comments, how many sleep disorders do you think there are? I'll tell you in a little bit how many there are, but I'd love to know what you think. Okay, so let's move on to questions to ask in your workup. So if you have seen my YouTube videos, you'll know that one of my latest videos is on the CSH framework for working up sleep issues with your patients. And so I'll talk about that a little bit. And essentially, it's just a really nice way to have a structured conversation with patients, just to have these bullet points in your mind so that you can make sure you hit all the points. And it's going to help you figure out what's going on with their sleep and kind of get at this differential. So C stands for circadian rhythm, S is the sleep drive, and then H is hyperarousal. So these are the 3 points that I have in mind whenever a patient comes to me with difficulty sleeping. So I like to assess their circadian rhythm, and you can do that in a really simple way. It doesn't have to take a long time in clinic. You can actually have a questionnaire that you give to patients before their appointment with you. So all of our patients get an intake questionnaire that in part assesses their circadian rhythm. And I have a handout in my sleep program on the different questions you can ask. But basically, some things you can ask your patient are, when do they usually go to sleep? So not just when they go to bed, you can ask them that too. Those are 2 different things, when they go to bed, and then when do they fall asleep? When do they wake up naturally without an alarm? So if they didn't have to wake up for school or work or use an alarm, what time would they naturally wake up? And then what's their sleep schedule like on weekdays versus weekends, or school days versus days off, or whatever their lifestyle is? Is there a lot of variability in that? So that's what we're kind of looking out for. And then, do they use an alarm to wake up, or do they wake up spontaneously? And then also asking them about their daily routines. So I like to know when they're getting light exposure, when they're getting exercise, when are they having their meals. All of these different things are relevant, and they'll give you a sense about how regular their routines are, or if there's a lot of variability. And so there's lots of different circadian rhythm disorders, but the 2 big ones that I'm usually on the lookout for are delayed sleep phase, like I mentioned in that first young patient, and then advanced sleep phase. So delayed sleep phase is when the person's body clock is delayed relative to their daily obligations. So this is your classic teenager, young adult, or even older adults can have this too, where they can't fall asleep till midnight, 2, 3 a.m., and then they could sleep till noon or later. And they really struggle with getting up on time for school or for work. It's painful for them to get up. They might have a lot of sleep inertia when they first get up. So that's kind of, in a nutshell, your delayed sleep phase. Advanced sleep phase is the opposite of that, and we tend to see this more frequently in older adults. And this is where they fall asleep too early and then they wake up too early relative to what they want or their daily obligations. So this is your patient who maybe falls asleep at 8 p.m. and then they wake up at 4 a.m. and they're wide awake and they're ready for the day. And they might get misdiagnosed as having early morning awakenings or depression. So that, again, is more classic in your older adult population. So these simple questions that I just went over for the circadian rhythm can give you some insight into what's going on there. And then there's other types of circadian rhythm disorders as well, which we're not going to go into today. The next part of the framework is the S. So this is the CSH framework. So if you're just tuning in right now, I'm just sharing some questions to ask in your sleep assessment when a patient first comes to you with sleep issues. And so the framework that I like to use is the CSH framework, which is kind of just something that I made up, but it's really helpful because I have these 3 bullet points in my mind whenever a patient comes to me. So circadian rhythm, the S stands for sleep drive. So here we're asking them about their patterns of sleepiness, their patterns of alertness. So at what time of the day do they feel most sleepy? When do they feel most alert? Are they taking naps? That's going to give you some insight into how strong their sleep drive is, or if there's some issue with sleep drive that's impairing their ability to stay asleep or fall asleep at night. We want to be asking about caffeine use. So caffeine blocks the adenosine receptor. Adenosine is a neurotransmitter that builds up the longer that we stay awake. And adenosine is largely implicated in the sleep drive. It makes us feel sleepy. And so when people use caffeine, it blocks that adenosine receptor, so adenosine can't bind, and then it blocks that sleepiness feeling. But once the caffeine wears off and unbinds from the receptor, the adenosine was still building up in the background. So then you get this flood of adenosine, and then people feel really tired. And this is why you might find patients drinking multiple cups of coffee throughout the day. They might need another one in the afternoon because their morning cup wore off. Now they have this flood of adenosine and they're extra sleepy. And then the lineup around, Starbucks is around the block at this time, 2 or 3 p.m. in the afternoon. So that is part of the sleep drive that we want to assess. An important aspect of assessing sleep drive too is asking patients how much time they spend in bed. Because you'll find that often patients who have insomnia, they want to spend more time in bed hoping that they're going to get more sleep. Logically, it kind of makes sense, right? They want to give themselves a better opportunity to sleep. But actually what's happening is the more time they spend in bed not sleeping, the more it feeds into hyperarousal and anxiety and reduces their sleep drive and makes it harder for them to sleep. So this is one of the principles behind sleep restriction, which is an aspect of CBTI, or cognitive behavioral therapy for insomnia. So again, we'll go into that in a future live. I'm going to be doing a series of these live videos over the next few weeks, so we can talk more about that. And if you guys have questions, please put those below and we can look at those. But that is essentially your sleep drive that we want to be asking about. So their patterns of sleepiness and alertness, naps, caffeine, how much time they're spending in bed. So that's in a nutshell. And I go into more detail in this in the YouTube video, so you can check that out later if you want to learn more. Okay, then the H in our framework is hyperarousal. So there's lots of different things that can cause hyperarousal, but essentially what I'm referring to here is when the patient's nervous system is activated, so they're in their sympathetic or fight, flight, and freeze aspect of their nervous system, which is incompatible with falling asleep. We need to be in the parasympathetic rest and digest aspect of the nervous system to fall asleep. So we're going to be assessing for hyperarousal in this part of the framework. So what I tell patients is that good sleep starts during the day, because often you'll find that the patient who's struggling with sleep is trying to do their headspace meditation right before they go to bed, or they're listening to their Calm app or something like this. They've been in a heightened state of stress all day long, and then they're trying this 10-minute meditation right before bed, and they're like, it doesn't work. Well, it's not going to work because you're in this heightened state all day, and then just trying to focus on relaxation at night is just, it's not going to work that way, right? So we need to focus on what we're doing during the day to help regulate our nervous system so that it's easier to fall asleep and stay asleep at night. So when I'm assessing for hyperarousal, of course, we want to be asking about stress. What's the patient's stress or anxiety levels like during the day? We want to be asking about the relationship with sleep. Is sleep a stressor for them? Are they anxious about going to bed? Are they worried about their sleep? Nowadays, you might find that a lot of patients are focused on their sleep quality. They might be using a Oura Ring or a Fitbit or an Apple Watch to track their sleep quality, and sometimes that actually feeds into more anxiety about sleep, which is called orthosomnia. So we want to just be asking about that, just getting curious about, okay, like, tell me about your relationship with sleep. How do you feel about it? Is it a stressful thing for you? Then we also want to be assessing for medical issues and sleep disorders that contribute to hyperarousal. So again, back to our differential diagnosis of obstructive sleep apnea. So if the patient is not breathing properly throughout the night, if their oxygen levels are dropping throughout the night, that's going to put the body into sympathetic nervous system arousal. So that's going to contribute to hyperarousal. Are there psychiatric conditions that might be contributing? So anxiety, depression, trauma, other things that haven't been addressed, other medical issues, thyroid issues, metabolic issues, cardiac issues, and so on. So all of these kinds of things can feed into hyperarousal. So we want to open up a conversation about that. Of course, you're not necessarily going to have time to go into all of these things in one visit with a patient, but you can even put this framework into your notes and then just make a note to go into each of these aspects at future visits. And what I tell patients is that figuring out sleep, it's going to take a little bit of time. We're not necessarily going to get to all of this today, right? So let's schedule another appointment and we'll go over these different aspects. And you can even partner with them and tell them, these are the 3 categories that I want to assess with you, and let's go through this step by step. And patients often respond really well to that because it helps them make sense of what's going on, because sleep can often be a little bit murky, like it just feels like this intangible thing, like you're trying to catch a puff of smoke or something. So having this framework can be tangible for people, and it gives them something to think about and work on as well. So it's a nice way to collaborate with your patient. So again, if there's any questions, comments, please feel free to contribute those. So I'll share some basic questions that I like to ask patients about their sleep as well as part of this assessment. So we talked about their relationship with sleep. Is it a stressor for them? Is it a source of anxiety? What's their relationship like with their bed? I do really like to ask them about their bedroom. You can get a little bit nosy here, but you might find that you gather information that they wouldn't necessarily have thought to share otherwise. So just like the example of the patient I shared at the very beginning who was sleeping in her closet, asking them about their bedroom is going to give you a lot of really useful information. And I think in my YouTube video that's coming out soon, I go into a little bit more detail on specific things to ask about the bedroom, but just ask them about their sleeping environment. So that's one thing I like to assess. Also asking them, do they feel refreshed in the morning? That's a really simple question. And patients will be able to give you some details on that. Are there days that they feel more refreshed than others? This might give you some clues about their circadian rhythm, like we were talking about earlier. You can ask them how many hours of sleep they typically need to feel refreshed. You can ask them if they feel sleepy or tired during the day. Are there times during the day where they find it really hard to focus or to keep their eyes open? This can give you some insights, again, into their circadian rhythm and their sleep drive. I also do like to assess for restless leg syndrome. So this was one of the differentials that I mentioned earlier in the 4 big differentials that I like to look out for. So here you can ask them, do you have an urge to move your legs at night? Do you feel like you need to wiggle your toes or to move around? Is it hard to get comfortable? Do you ever have a creepy crawly sensation in your legs or a tingling feeling? Because restless leg syndrome, or RLS, can often show up as insomnia, sleep onset insomnia. And if we're not asking for it, patients might not volunteer that information because they might not know that it's relevant. So these are all questions that we can be assessing. So that, in a nutshell, is the history, so the CSH framework, and then going into a little bit more detail on those questions. And then there's a few rating scales and tools that I also like to use in conjunction with the history. And you can either give these to patients before the session or after the assessment, depending on how what your workflow is like. But there's a few basic ones that I like to use. So one is the Epworth Sleepiness Scale. So the Epworth Sleepiness Scale is going to assess for their daytime levels of sleepiness. And this is a scale that you can download and put into your intake packet. And we give this to every patient in my practice. So it's a scale that's going to tell you, it's basically out of 24, it's going to tell you what their daytime sleepiness is like, and a score of 10 or more indicates excessive daytime sleepiness. Less than 10 is considered normal. And just a couple quick pearls, and I have more detail on this in my free mini sleep course, but a couple pearls on the Epworth is that for patients with insomnia, they're often going to score really low. Like they might have a score of just like 1 because they have so much hyperarousal that they don't feel sleepy during the day, right? And so that's just a clue that, okay, maybe we need to work on this hyperarousal piece first. So that's the Epworth. And then if it's more than 10, we're thinking about excessive daytime sleepiness. Is there hypersomnia? Is there something like narcolepsy, or is this medication induced? Are they just sleep deprived? Is there insufficient sleep going on? Do they have some kind of anemia, iron deficiency, things like this? So just some ways to get clues that you'll then correlate with your history. Another rating scale that's easily accessible is the Stop Bang questionnaire. And this is one you can use to assess for sleep apnea in your patients. And a few caveats about the Stop Bang questionnaire is that it's good for assessing people who have the classic symptoms of sleep apnea that I mentioned before. So, the overweight with the 17 plus inch neck with loud snoring, gasping arousals, those kinds of symptoms. So it may miss symptoms in patients who are less likely to have those classic symptoms, like women, as I mentioned before. So you take that with a grain of salt, but it's just a nice screening tool that you can easily incorporate into your practice. And then another tool that I like to use is the AASM Sleep Diary. So the American Academy of Sleep Medicine Sleep Diary. It's not really a rating scale, but it's a really nice tool. It's free to download. You can download the PDF. And so we give this to our patients in our practice. And it's a 2-week grid. It's easy for them to fill out. It's self-explanatory. The instructions are on the PDF itself. And what I like about this sleep diary is that it gives you a nice visual. I should have actually pulled up an example. I could have shared my screen and showed you, but maybe I'll do that next time. But it gives you a nice 2-week grid of visually what their sleep patterns look like. And this is a nice tool for looking at circadian rhythm. So you might notice that the patient's sleep is really delayed on weekends or vacation or days off, and then it's earlier on their school days or work days. It can give you a sense as to their sleep drive and if they're taking naps and things like this. Because even patients don't remember what was their sleep like last Wednesday, right? Like, I don't remember. I'll have to think about that. So it's just a nice way to kind of capture that data and get it in a nice visual format. Some of my patients do use wearables. So instead of doing a sleep drive, sleep diary, they might use their wearable to get that data, which is fine too. But the sleep diary is a really nice tool. So I think we'll wrap up there. We're almost at the half-hour mark. So I'm going to go live again next Wednesday, January 31st. That one's going to be at 5 p.m. Pacific time. And we're going to talk a little bit more about sleep assessment and other questions that you can ask. If there's anything that you want me to talk about, again, you can post that in the comments below. If you're watching the replay, you can put that below, and I'll be happy to go into detail on those different aspects. And then stay tuned, because I'm going to be opening doors to my sleep program next month, and I'm going to be doing some free webinars on sleep supplements, which is kind of fun to talk about because I get those questions all the time from patients and even from other physician and therapist colleagues. So I'm going to be doing some live webinars on sleep supplements. So I'll post more details about that later. And then if you'd like to go deeper into some of the things I just talked about, you can get my free sleep mini course, and that's at intrabalance.com/doctors, and I'll put that in the comments below so you can see how to access that. And that's totally free, and you get CMEs, and it's kind of fun, and you get to learn a little bit more about these aspects of sleep evaluation, because most doctors only get 2 hours of sleep medicine education in med school, but all of our patients have to sleep. So I hope you enjoyed this. If you found it helpful, please share it with another physician or therapist in your life who could benefit from this information. And then I'll see you again next Wednesday, January 31st at 5 p.m. Pacific. Bye for now.